Kristen Atchison, and we're still talking about psychological disorders. This is the second part of this chapter, and we're going to be talking about anxiety disorders. So anxiety disorder, we are all familiar with anxiety. We all have anxiety about different things. But the experience of anxiety really becomes a disorder when it becomes maladaptive and it's uncontrollable. So anxiety is good for us if we're using it in adaptive ways, if it's helping us make sure, I have anxiety about missing the bus for my daughter at school. So it makes that anxiety helps me get to the bus stop on time so that doesn't happen. So that's adaptive. But if it's maladaptive, that would keep me from getting other stuff done. If I was so consumed by that anxiety about, am I going to miss the bus? Is my daughter going to be stuck on the bus because I wasn't there to pick her up? And I'm so focused on that I can't get other stuff done, that's maladaptive. That's disrupting my everyday mood. And so while we all have anxiety, anxiety disorders are, again, just like we talked about with this disorders in general, when it's disrupting our life, when it's maladaptive, when it's dysfunctional. And so we'll see that anxiety disorders are the same thing. Once we cross that threshold into disrupting our everyday life activities, moods, thought processes, once we cross that threshold and from it being a helpful thing to help us get stuff done to a maladaptive thing that keeps us from getting anything done, that's where we'll see that crossover between disordered and not disordered in terms of anxiety. Now, there's several different anxiety disorders that we're going to discuss in class. Generalized anxiety disorder, panic disorder, phobias, obsessive compulsive disorder, and post-traumatic stress disorders. All of these are anxiety disorders. They're all somehow we have a problem with that fear because anxiety is coming out of fear, and it's become maladaptive, and it's disrupting our everyday moods and activities. So generalized anxiety disorder is kind of this continually tense, fearful state. So our autonomic nervous system is always aroused. This kind of constant low level or high level anxiety, this high level arousal all the time. So we have the symptoms would include a persistent state of worry, being jittery or on edge. This is going to cause people to be sleep deprived. They're not going to get enough sleep because they have this consistent state of worry. They're jittery. That's going to make it hard to go to sleep. So we'll see sleep deprivation. Fixation on potential threats. So really being focused about this thing going wrong or this thing going wrong. Really this potential threat, this is where their attention is focused. Because of this, they're going to have a difficulty concentrating in other areas because this fixation is so on these possible threats. Now, these are not probable threats. These are possible threats. What's become disordered is that these aren't things that are likely to happen. These people aren't worried about things that are likely to happen. And we see these individuals will have an inability to identify the cause of the tension. They won't know why they're so stressed out. They won't know why they're so worried. And this is generalized anxiety disorder. So it's kind of this overall kind of feeling of anxiety, really this focus on different potential threats, and it really affects the person's ability to function because we have this sleep deprivation, we have this difficulty concentrating, because the mind and the thoughts are being so taken up by worry and these potential threats, and they're not able to kind of hone in on where this is coming from. Panic disorders are really characterized by this unpredicted kind of episodes of intense dread. So generalized anxiety disorder is kind of all the time. A panic disorder is when we have this episode of intense anxiety. And this really is like terror. This feels like you're having a heart attack. This feels like you can't breathe. This feels like really huge, huge reactions, huge bodily reactions that feel life-threatening. Because this feels so terrible when an individual has a panic attack, when they have this episode of panic, they start to worry about having another one. And so this becomes really problematic. These attacks are recurrent, so they happen frequently. And because of this fear about these attacks, individuals may avoid situations that may cause them to panic. Really extreme cases of this would be something like agoraphobia, where someone's not going to go outside because they're trying to avoid things that would make them have a panic attack. And so to avoid that panic attack, they're just not going to go outside at all. And so this is where panic disorder could lead into something else because they're so worried about not having another one of these panic attacks, because it does feel really terrible. I mean, chest pain like you're having a heart attack, choking like you can't breathe. I mean, those are really scary events. And so to avoid that, this can lead to other kinds of phobias where to avoid these panic attacks. So a lot of times these panic disorders may go hand in hand with phobias. So examples of phobia, again, agoraphobia is this avoidance of situations because of a fear of having a panic attack. And we can have all different kinds of phobias. If you can think of it, there's probably a phobia for it. But again, that phobia is where it's maladaptive. So this isn't just you don't like snakes. This is, you won't go to the zoo or you won't go to the woods or you won't go outside because you're afraid you're going to see a snake. So that's maladaptive, where it really is interfering with your everyday life. So phobias, again, we have to have that maladaptive, that disruptive function of them. Social phobia is another example. This is an intense fear of being watched or judged by others. It's visible as a fear of public appearances in which embarrassment or humiliation is possible. So public speaking, it can even be things like eating. People are afraid they're being watched eating. And again, this is going to be maladaptive. They're going to avoid situations where they might be watched. And you can see how this could be disruptive to someone's life. Obsessive compulsive disorder, we in our culture talks about obsessive compulsive disorder as if we all have it, if we're worried about germs and we like things clean. No, that's not obsessive compulsive disorder. Again, it is disruptive to the individual's life. This is not something where they like things straight and tidy. This is not necessarily just about cleanliness or orderliness. This is about, again, this disruptive pattern of life. The clients that I've worked with that have had OCD weren't necessarily clean freaks, right? So we talk about those things as they're synonymous in our language, and they're really not. So his apartment was not clean. I mean, it was ordered, but it was not clean. But, there were things that he had to do, and he had to do them in this exact order. He had to go to a restaurant and order the same food every single day. Didn't matter that he had lost his job. It didn't matter that he didn't have the money to do it. It didn't matter that he was not going to be able to pay his other bills because he had to go to this restaurant and eat this particular meal. That was maladaptive. That was disruptive. So those are the kinds of things. That obsession had him compulsory to repeating this ritual. We'll see it with the obsessions are going to be the repetitive thoughts. So concern with germs is one of the kinds of things. But again, just because you don't like germs and you use a lot of hand sanitizer and you like things to be clean does not mean you have OCD. And so this vernacular that we use, that they're synonymous, is really harmful for people who really do have OCD and need treatment, but for people who don't have OCD, and that's just their normal behavior. So again, this vernacular is not beneficial. So common pattern in OCD, rechecking, although you've already made sure the door is locked. This is not, I know I'll do it on my way to campus. I live far from campus, so when I come to campus, sometimes I'll reach back and just double check my laptop's in my bag while I'm driving down the road. This is not rechecking it once. This is rechecking it 15 times. This is rechecking it 25 times. This is having to turn back and make sure that my laptop is not on my desk. This is really, again, really maladaptive and disruptive. This is not just one check. This is rechecking and rechecking these sorts of things. This graph right here is the percentage of children and adolescents with OCD reporting about obsessions and compulsions. So again, we'll see that excessive hand washing and bathing, other grooming behaviors is really, really high in terms of repetitive behaviors. We're not talking about washing your hands, 10 times a day. We're talking about washing your hands until they bleed. So this is maladaptive behavior. This is disruptive behavior. Rituals in and out of a door. So sometimes, you have to do it 15 times. And then 15 times doesn't feel good anymore. 15 times doesn't make that anxiety go away. So then you got to up it to 20 times. Because then I feel better when I've done it 20 times. So again, this is maladaptive. And it's not something where it's just a ritual that's, that stays that ritual forever. That ritual starts to not be enough to keep that anxiety away, to keep that kind of heightened arousal away of the autonomic nervous system. And so those things usually become more compulsive. You need to do it more times before it helps relieve that kinds of behavior. Another one that we talk about in anxiety disorders is post-traumatic stress disorder. We see that about 10 to 35% of people who experience trauma not only have burned-in memories of those events, and if you've experienced trauma, it's hard sometimes to forget that event. So that burned-in memory is not PTSD, but they also PTSD is going to also have this repeated intrusive recall of those memories. Again, to a disruptive level. Again, to a maladaptive level. This can also include things like nightmares and re-experiencing of this. Avoiding social settings or kind of a phobic avoidance of things because there are things that will trigger those thoughts, that will trigger those memories. You'll see there's signs sometimes around New Year's and the 4th of July that says in people's yards, like, hey, this person this is a military veteran who has PTSD, and the fireworks do not help because they sound like they're gunpowder going off, right? And so they sound like that. And so avoiding situations because they could trigger that. Jumpy, anxiety, hypervigilance. A lot of times we'll see insomnia or sleep problems with an individual with PTSD. Now, again, only about 10 to 35% of the people who experience trauma are getting this. So we see that people with PTSD there are factors that can contribute to who's more likely to get it. One of those include people who have less control in the situation. So children, a lot of times, can develop PTSD from a situation because children don't have a lot of autonomy in situations. They don't feel like they can fix things. So we'll see that a lot of times when someone's younger, that's more likely to develop into PTSD because that sense of control is not there. We talked about that, how that sense of control is really important in our health and our well-being. And so people who have less control in that traumatic situation are more likely to develop PTSD. People who are traumatized more frequently. Again, we'll see people that are abused, whether it be physically or sexually. Those things rarely happen just once. They happen repeatedly, especially when it's done by a family member or someone close. And so again, these things that happen more frequently are more likely to develop to PTSD. This is also true of people in the military. Rarely is there just one situation where there was explosions, where there was, really dangerous things going on. And so the frequency of which that happens can really exacerbate the people, these fears, and make it more likely. that they'll develop PTSD. We also see that brain differences are going to play a role. The amygdala is really important in fear, and we see that people that have a smaller amygdala are more likely to develop PTSD. So again, looking at it from that biopsychosocial approach, that biology makes a difference. It's not just the person's control of the situation, which would be the of the psychosocial, right? It's not just the psychological characteristics, it's also the biological characteristics as well. Resiliency, people who don't have the ability to kind of up from things, who don't have kind of the toolbox in which to cope with these things. Again, people who get re-traumatized can, again, the more times that these are happening, the more likely it's likely to happen. And the PTSD can also, when they relive that, that can be traumatizing in and of itself. And so again, it starts a cycle that really kind of keeps feeding it itself. And again, that genetic predisposition or family history, not just of PTSD, but of anxiety. PTSD is, again, an anxiety disorder. We are talking about fear, and anxiety is just low-level fear. And so we'll see that people who have a family history or have anxiety are more likely to develop PTSD. So our biology, our genes do make a difference in anxiety disorders. We'll see that identical twins, remember these are going to be genetic clones, are more likely to both have anxiety disorders, even if they're raised separately. So even if we take out that environmental component of a stressful environment or a traumatic environment, these genetic predispositions really are prevalent. We'll see that infants who are really high strung at birth, again, this is evidence that this is more lifelong, this is more genetic, that can contribute to that. Again, genes and the neurotransmitters are going to be the big things. Genes really regulate how the neurotransmitters are released, how the body takes the neurotransmitters up, how these neurons communicate with each other. And that's how those neurons communicate with each other it results in whether we have anxiety or not. So we'll see a big component of that. People that have a gene that triggers high levels of glutamate, which is an excitatory neurotransmitter that's involved in these brain's alarm centers. We'll see that those people, they have a gene that releases more glutamate, which tells your brain that it's on a high alarm. And so those people are more likely to have anxiety. We also say that the amygdala plays a role in this. The amygdala is the fear center of the brain. And so these traumatic experiences can really kind of burn in these memories into the amygdala. Not really burn, but into this pattern of reliving it, this pattern of fear. And so these circuits can be later triggered and activated by things that are similar. They can be generalized to other situations, which can increase anxiety. Anxiety disorders also include areas of the brain that are involved in impulse control and habitual behaviors. You can see that especially with somebody with OCD. You can see that with somebody with generalized anxiety disorder, this fixation on these potential threats. This could be a problem. Here's a picture of a person with OCD who has extra activity in the ACC, which is the anterior cingulate gyrus. And this is one of the areas of the brain that's really responsible for checking our actions and checking to see if those actions have errors. So if those actions needed to happen or if they didn't, or if those actions happened appropriately. And this part of the brain in a patient that has OCD shows extra activation. This is going to account for some of those compulsions, those repetitive behaviors. Again, not noticing when there's an error, not noticing that doing it 15 times is an error, not monitoring those actions appropriately. So this concludes our discussion of anxiety disorders. Thanks.